Hello, everybody. Welcome on this second webinar for this year, on this beautiful day today along the Belgian coast. And as you know, I can't start the day without having a look at the beach, of course. Well, I'm really thrilled about the event today because we have about 568 participants who registered for this webinar. So that's really, really phenomenal. And from those 568, there are about 235 guests who are for the first time joining an EDGOM Global Cyriax Institute event. So that's really fantastic. As usual, I'm broadcasting from our International Training Center over here in The Haan, where we offer the Mastermind private training. So if you want more information about that, just have a look at this website. Of course, I'm not doing this alone. Together with my international teaching team, we offer courses all over the world. Here are my team members, colleagues from Italy, Slovenia, Bangladesh, Argentina, a nice, small but efficient team. So what are we going to do today? Today, we're going to talk about traction, lumbar traction. And in the meantime, I see in the chat that Christo from Bulgaria is already there. Welcome. Christo is one of our course organizers in Bulgaria. By the way, I would like to thank all our course organization partners from Bulgaria, from Slovenia, Croatia, Poland, Malaysia, Taiwan for their help in announcing this webinar. Thanks to them, we have so many participants, and of course also thank you to my team members. In the meantime, we have some guests over here from Slovakia and Argentina. Welcome, everybody. So once in a while, I'm going to have a look at the chat, but of course, I also have to focus on my presentation, so it's not always that easy. So I hope you are in a relaxed atmosphere right now. No disturbance from husbands, wife, children, dogs, whatever, but that you can focus 1 hour on some beautiful content I'm going to share with you. Well, okay, what may you expect? The story about lumbar traction, and of course, we're going to also spend some time for Q&A from certainly we'll have some questions. And in the meantime, you noticed when you did the registration procedure for this webinar that you could already ask some questions. Well, you did your best. About 100 people sent in their questions, and a lot of interesting questions. And the good news is, on most of those questions, you're going to get an answer during this webinar. So that's going to be fantastic, I think. But there are still, when I have a look at those questions, there are still some other interesting questions, which I'm going to refer to at the end of the webinar, because there are some other things I would like to share with you. And of course, for those of you who can't be here live on this webinar, you're going to receive the replay version of this webinar. You're going to receive that through email as usual, but the replay link is valid until 3 days after the live broadcast. Okay, so after 3 days, you can't watch it anymore. And for those of you who stay until the end of the webinar, then you also get a little reward. You are going to be able to download all the slides of this webinar, also the scientific slides, and you're also going to receive a special handout on the topic from today. So, I'm curious about your experience. Is there anybody in the group who already did mechanical traction on a lumbar patient, and afterwards, immediately afterwards, after the traction, when the patient steps down from the traction table, the patient was much worse? Did you already experienced that. I'm looking at the chat to see if there's somebody in the group who already said, I already got misery with traction. But when you type something in the chat, there is some delay. You type it, and just a few seconds later, I'm going to see that over here. So, well, I already experienced that. It already happened that I gave a patient mechanical traction, and afterwards it was much worse. And then, of course, it's very interesting to know why is he much worse. Well, on this question and many other questions, I'm going to give you, hopefully, I'm going to give you a nice answer. Well, today's travel starts in the southern part of Belgium, more specifically in the city of Bouillon. That's a small city very close to the French border. And in this city you have an old castle, the castle of Bouillon, and there is a very interesting room, the salle de torture, or more specifically, the torture room. And what can you find in the torture room? Well, you can find the medieval version of, let's say, the combination of dry needling and mechanical traction. Of course, nowadays we're not going to do that. That seems logical. Yeah. But the title of the webinar, yeah, is it old-fashioned, yes or no? When I scheduled this webinar, I asked myself, am I going to do that, yes or no? Because I had some doubts about the topic. Because certainly in Central Europe, mechanical traction is not popular anymore. I don't know many colleagues around me here in the neighborhood who still have a traction table, and even less colleagues who are using traction. That's not so popular. It's old news. It's old-fashioned. Is it old-fashioned? Well, yes, it is old-fashioned. It's nothing new. Some time ago, I received this picture from a colleague in Saudi Arabia. That's a little bit unpractical to do traction, of course, but the concept of traction is nothing new. Even the old Incas knew that. But what you see on this image is an illustration from a medical book, and what you see over there is the combination of traction in a cranial direction, in a caudal direction, and the therapist is doing some kind of extension impulse. Okay, I can imagine that at that time, certainly accidents happened. I'm sure about that. But the idea that we have to open something, we have to create some space in order to resolve some kind of back problem, this is an old-fashioned idea. Also, this illustration from another medical publication, well, what you see over here, also the incorporation of traction in two directions, and a therapist who is doing some kind of manual extension manipulation. So already hundreds of years ago, they did this. And actually, today, in certain situations, we're still going to do some similar things. But okay. Because it's old news, because traction is absolutely not new, because it's old-fashioned, are we going to throw it into the garbage bin, or are we going to do something else with it? Well, my suggestion is that we don't throw it in the garbage bin, but that we have a look at what we can change to optimize some things. Because in my experience, from what I hear all over the world, one of the main reasons why people don't use mechanical traction anymore is because it's not efficient. It doesn't work. It's useless. Okay. But what is the main reason for which it's not efficient? I noticed that many people don't follow, let's say, an optimal procedure. They put the wrong patient on the table, the wrong clinical image, intermittent traction instead of constant traction, not enough kilograms, not an optimal position, and so on, and so on, and so on. So those are the things I would like to go through with you today, so that if in the future you're going to do mechanical traction, that in fact you respect some kind of interesting modalities which are going to have a positive influence on the efficiency of our traction. Yeah. This was a remarkable way of doing traction I saw years ago. I think that was, if I remember well, that was in Philadelphia, in the United States. It's not bad, but it's absolutely not practical. So giving traction from a prone line position is mostly not very comfortable for the patient. And as you can see on the image, the patient who has to hold on to herself and has to take care of her own fixation and lie there for about 20 minutes, this is not practical. So we're not going to do that. A question I get so often is, yeah, we have here this cage with the pulleys and everything. Can I use that to do traction? Well, the answer is yes, but no. Yes, you can do it, but it is phenomenally unpractical, and it's not comfortable for the patient, and most likely you're not going to be able to build in enough traction force by using such a system. So preferably not. What do we see over here? Well, we see a nice traction table with a traction unit. Okay. If I remember well, that was during one of my first visits in Bangladesh, and I was really surprised to see that. I was positively surprised. But the downside of the story was that at that time, all the things you could do wrong was wrong. Nowadays, they optimize things. Nowadays, okay, it's a more positive story. In the meantime, I see here in the chat, Olona, you're asking, what about the inversion table? Well, I come back to that on a later moment, if that is okay for you. But for instance, I refer again to this picture you see now. What you can't see is that lady got a traction of 15 kilograms. Well, we're going to see later on that 15 kilograms is not so efficient. If you look at the pelvic belt that lies entirely on her breast, this is really not very practical for that lady. But this was a lady, if I'm not mistaken, from 74 years old. You don't put elderly patients on a traction table. Later on, we're also going to see that this is not one of my patient selection criteria. Elderly patients most likely are not going to react very well on traction. So keep that in mind. Yeah? So what do we need? Well, what you see on the left side, some kind of home auto traction system. I tested that, I played with that, but to be honest, I wouldn't spend money for that. I find it highly unpractical, not so efficient. For me, it's not a super alternative. If you then look at the two other tables you see on the image, well, you can spend as much money as you want for traction tables, but it doesn't have to be that expensive. You don't need those complicated tables. And if you look at the table on the right side, you see those medium parts which are movable. Yeah, I come back to the previous picture. You see also on this picture there's a part in the middle that moves, that shifts a little bit. This is the so-called traction table. Well, dear colleagues, you don't need that. This is just marketing. I have nothing against it, but you don't need it. Yeah, it doesn't change anything regarding comfort of the patient, efficiency, and after all, yeah, efficiency is a very important thing, of course. That doesn't change anything. So if you have the opportunity to buy a more simple table, because of course those kind of tables are, of course, more expensive, you don't need that. So one more time, okay, I have nothing against it, but we really don't need that. And the table I have in my clinic here at my home is just a basic table, a basic high-low table, a hydraulic high-low table, and that's it. I don't need more, with the flexion bench and with some cushions, and that's it. This is, let's say, one of the more cheaper options and one of the better options, because I can also use that table for other purposes, not just for my traction patients, but if I want to do some manipulation techniques or mobilization techniques or whatever, I can also use that table, of course. Yeah. Okay, what is the effect? What is the effect of mechanical traction? Well, actually, we have three effects. You open the door, you create space. Okay, automatically that happens. It depends a little bit, of course, on how many kilograms you use, but more about that later. The second effect is, of course, you get more tension in the posterior longitudinal ligament. And let's imagine the patient has a lumbar internal derangement. He has a lumbar disc protrusion or disc bulging, whatever, with pressure against the dura mater or pressure against the nerve root. What happens when you open the door? When you open the door, you also create, as you can see, a negative pressure. You get a kind of suction force. And thanks to this suction force, certain types of internal derangements, certain types of disc protrusions can reduce. And certainly with more central disc protrusions, where you also have pressure against the posterior longitudinal ligament, well, when you put tension on the ligament and there is some kind of internal derangement exerting some pressure over there, then automatically this tension in the ligament is also going to help to push back the internal derangement. But in fact, it's a combination of three elements which are happening. And yes, you can create space. If you look at this X-ray, in fact, those are two X-rays, one X-ray without traction and one X-ray with 50 kilograms of traction for about 10 minutes, and then you superimpose the two X-rays, then and have a look at the position of the transverse processes, then you clearly see that you get space, you get an opening. Okay, so what? We get an opening. It's not because we get an opening, you're going to reduce all the lumbar internal derangements. It's not because you get an opening that traction is interesting for all back patients. Absolutely not. Yeah. This is a super old image. Super old, 1968. But I still want to show it to you because it shows something interesting. You can clearly see that there is some kind of disc protrusion, and then during the traction, you see that the distance between the vertebra increases, you get an opening, you get a negative pressure, and you clearly see that this internal derangement reduces. And after the traction, what do you see? Okay, back vertebra in so-called normal position, body weight, gravity force, there is some protrusion again, but if you compare that with the image on top, it's clearly less. So yes, you can reduce protrusions. This is old news. This is the easy part. Difficult part is, how do you keep it reduced? I can already tell you now that traction has no long-term effect. Manipulation has no long-term effect. Mobilization has no long-term effect. If you're looking for a long-term effect, we also need something else. We need a good prophylactic strategy. But that's going to be a topic for one of my next webinars. And there are quite a lot of references that show that you really get this negative pressure and that you get a reduction of disc material or disc protrusion in certain situations. Remember, at the end of the webinar, I give you the slides so you can have a look at those references whenever you want. Of course, I not only have images from 1968, but also more recent images. And I got those images from a doctor from Poland who attended our lumbar spine course. And on the left side, you clearly see a beautiful internal derangement, disc protrusion. And on the right side, after treatment, you clearly see that the protrusion reduced. It's not fully okay yet, but it reduced. And you see that on both of the images. So yes, you can influence the position and the size of some internal derangements. But the problem is always selection of our patients. Yeah. As I said you before, you're not going to put every back patient on the traction table. And which patient are you going to put on the traction table? Well, I show that to you a little bit later on. Here you see the same. Yeah, if you compare on the left side the protrusion and then after treatment on the right side, there is some difference. And more references that go in the same direction. But as I told you, it's not for every back patient. That would be nice, but we have to be realistic. No, it's not for everybody. So what are our indications? Well, actually, to be honest, there's only one patient who is indicated. Only one. Or one type of patient. But fortunately, we see this type of patients quite a lot. And which patient is that? That's a patient with a lumbar internal derangement with a so-called, what we call a nuclear lumbar internal derangement. We also call that a soft internal derangement. And this patient has a typical story. And this is a story that most of you know that. Most of you see that. If you ask the patient, tell me, how did it start? And then you're going to hear a story that goes in following direction. Yeah? Yesterday or the day before yesterday, they were working intensively in the garden. And in which position were they? Constantly flexion, 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 rotation, flexion, rotation, flexion, rotation. And at the end of the day, they felt their back. They say, oh, I feel my muscles. Yeah, I have some soreness in my back. I did a little bit too much today. And then they sit on the couch in the evening watching some television. Most likely they sit in a very slouched position, in a kind of kyphotic position. And yeah, they feel some discomfort in the back. Then they go to sleep. And turning in bed from left to the right side is a little bit annoying. And then the next day they wake up with back pain, more than yesterday. And slowly but surely it gets worse. This is a typical story. Yeah? Unilateral loading on this spine, flexion, 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 rotation. Yeah? And then a slow onset of the pain. And the next day it's worse and worse. When you hear this is already one element. Okay, perhaps he's going to be a candidate for my traction table. But of course, you can't divide the disc in the nuclear part and the annular part. Yeah. Of course, there are two parts, but yeah, there is not a clear border between those two parts. We have to be a little bit realistic. And sometimes, or very often even, you hear the story of what we call a mixed internal derangement. And let me share that story with you too. This is the patient who says, well, some time ago, for instance, I was working again in my garden, or I did some other activities, and too much flexion, too much rotation, constantly moving in the same direction without compensation in the other direction. And after some time, he gets some slight back pain. Okay, but it's not too bad. I can live with that, yeah. And when I move a little bit in another direction, it gets better again. Okay, it's not too bad. That was about 2 weeks ago. But yesterday I picked up something from the floor. I was in the shower and my shampoo fell on the floor, and I just flexed to get my shampoo, and suddenly I got a twinge in my back here on one side. And since that moment, I have much more back pain. This is what we call the mixed story. A slow onset, but it's not too bad. And then, suddenly it's worse. Or the reverse. The patient who says, yeah, it started some weeks ago. Yeah, I lifted up something in the supermarket and I got a twinge in my back. And what's that? Yeah, I problem with my muscle or whatever. I got a sudden twinge, but it's not too bad. Then automatically it was better. But of course, he continues with his daily activities. And like most of the people, we have a unilateral movement pattern. Yeah? We do too much flexion and we don't do enough extension. We don't compensate enough. And slowly but surely it gets worse. Yeah. And 2 weeks later, it's disturbing him a little bit too much. And then he's looking for help. This is the mixed story. If you give this patient mechanical traction, most likely he's going to benefit from it, but not 100% result. Most likely, he will also need some sessions of manipulative approach. And of course, we never forget, of course, the prophylactic approach. Yeah? Okay. Then we have another indication, again, internal derangement, but a high lumbar internal derangement. Most of the internal derangements, most of the disc bulgings, the disc protrusions, most of them, they are low lumbar, L4, L5, L5S1, mostly. Yeah. But what you see over here is, if we have a high lumbar one, they seem to react better on traction in comparison to manipulation. But I don't have scientific proof for that. This is purely empirical. Yeah. But I think still useful. Yeah? Keep that in mind. This is also something nice, which is empirical. Let's imagine, picture on the left side, the patient has back pain. And during the functional examination, we ask the patient to do an active extension. And then we ask the patient, does that change anything? Don't ask the patient, does that hurt? No. Not a good question. And why is this not a good question? This is something I will explain also in another webinar or in our online masterclasses about interpretation of examination. So that lady, she has back pain and she does an extension. And I ask, does that change anything? And she says, yeah, it hurts. And then I ask, where does it hurt? And then she says, ooh, I get some radiation in my gluteal area, a little bit further through the leg. So extension is producing referred pain, is producing leg pain. This is unfavorable. We don't like to see that. And this is also an empirical element, that those patients don't react so good on manipulative strategy. They seem to react better on mechanical flexion. But again, this is, I call that a clinical pearl. Yeah, but it's empirical. And if you look at the right picture, let's imagine she has unilateral paravertebral back pain. Okay, and she does a side bending in standing. And I ask her again, does that change anything? And then she says, oh yeah, I get more pain there on this right side. So the homolateral side bending is increasing this pain. This is again an empirical element that patient could react better on traction. Little detail. At this moment, I'm collecting a little bit puzzle pieces, yeah? We're not going to have one single criterion to put the patient on the traction table. We're going to have a combination of different criteria, yeah? Keep that in mind, okay? The reverse. The patient, let's imagine she has pain on the right side and the back, and she does a side flexion to the left, or a side bending, and the right pain gets worse. Then we notice that this patient reacts a little bit better on manipulative techniques. Okay, why not? What else do we have as a possible indication? A primary posterolateral protrusion. What is that? That's something strange. Let me see. Just a moment. Let's have a look at this point. What is a primary posterolateral protrusion? Well, let me go to the big screen. That's going to be easier. Well, let's imagine somebody has a posterocentral protrusion, a posterocentral internal derangement with pressure against the dura. That's something that happens very often. But it is possible that somebody who has a central protrusion, he has, of course, central back pain, but at a certain moment, this protrusion is changing its location and goes more lateral. So you get what we call a secondary posterolateral protrusion. So not anymore pressure against dura, but pressure against a nerve root. So in other words, you get a secondary sciatica. A real sciatica is not so frequent, okay? The majority of people who have leg pain don't have a sciatica, but I refer to the previous webinar, which you can still watch on our online masterclass. More about that a little bit later. There I explain in the 7 tips and tricks regarding diagnosis and differential diagnosis that most of the people with leg pain don't have a sciatica. They have something else. Okay. So I hope this is clear for everybody. The central protrusion that at a certain moment goes unilateral and exerts pressure against the nerve root. What is a primary posterolateral protrusion? Well, this is this protrusion that goes out immediately posterolateral. So from the beginning, pressure against the nerve root. This is not frequent, but it happens. So this patient, let's imagine this patient has pressure against the S1 nerve root. What happens? He's going to have an S1 sciatica. He's going to have pain somewhere in the S1 dermatome, somewhere. But if this happened from the beginning, posterolateral, he never had back pain. If you ask him, what about your back? Everything okay? Don't have back pain. I just have pain in my leg, in my calf. There. Yeah? This is a primary posterolateral protrusion. If the patient has less than 3 months of leg pain, no back pain, this is a good patient for mechanical traction. But less than 3 months of leg pain and no back pain. This is also an empirical element, but if you see that, well, that's going to be very helpful to determine your strategy. Okay? Good. And another indication to put the patient on the traction table is the patient who tells you, give me traction. And how does he tell you that? Sometimes the patient says, well, I have to tell you something. In my garage, I have some kind of metal bar there at the ceiling, and sometimes I hang myself at the metal bar. I do some kind of auto traction, yeah. I hang with my body weight, and this relieves my back. This is more comfortable in my back. So the patient already tells you that by doing some slight auto traction, this relieves my back pain. Come, I'm going to put you on the traction table. I'm going to give you a little bit more kilograms. And then I come back to the question from Aulona. What about the inversion table? Well, yeah, the inversion table, you put the patient head down, feet up. You also get some auto traction. And some patients are going to say, yeah, that feels more comfortable. Put them on the traction table. The inversion table itself, I also, to be honest, I wouldn't spend any money on that, because when it really comes to therapy, efficient therapy, it's not so efficient. Yeah. And the main reason is that you can't build enough kilograms of traction. You just have a little bit of auto traction, but that's it. So the concept is okay, but the practical efficiency is not so okay. Yeah. So to summarize, who are we going to put on the traction table? A lumbar internal derangement. I'm only talking about internal derangements. In the questions I received here from many of you, people are asking about facet syndrome and other things. Forget it. There's no indication when there is a facet pathology, if that would exist, but that's another story. That's also something to discover in the online masterclass. Don't think of traction. There's only one reason to put a patient on a traction table. It's a patient with a lumbar internal derangement, preferably a nuclear internal derangement, and the other things we discussed before. But it is also very important to know when you don't put the patient on the traction table. Remember at the beginning I asked you, did you already have some misery after traction? And I see that Jean Casal in the chat says, yeah, it happened to one of my patients. Well, I'm happy that I'm not alone. Yeah, but we're going to see how we can avoid that. The main reason for not putting the patient on the traction table, although he has a lumbar internal derangement, is the hyperacute patient. What is hyperacute? This is the patient who is completely blocked. The patient is standing in front of you and you do your basic examination. You ask him to do an extension. Oh, very painful, completely blocked. And also perhaps with some radiation on extension. Side flexions, painful, limited. Flexion, painful, limited. Twinges. If the patient comes from sitting position to standing position, it's problematic. From lying position to standing position, problematic. If you put this patient on the traction table, perhaps during the traction he's going to like it, but after the traction he's not going to like it anymore. A second patient you don't put over there is the annular protrusion, what we call the heart protrusion. Remember the story? The patient was doing some kind of activity, flexion activity, rotation activity, and suddenly a twinge in my back. This is typical for what we call the heart protrusion. This patient is not going to react well on traction. He's going to react much better on manipulation, if he's indicated. Remember the picture from the lady in Bangladesh on the traction table? She was 70 plus. Doesn't make sense anymore, because we know that the disc, young patients, you have a softer nucleus, a harder annulus, but the disc is drying out. It's becoming less elastic. And certainly patients above 65, there's not too much difference anymore between nucleus and annulus. So this is one of the main reasons that traction with elderly people is not so efficient. It's more efficient with younger people. But where is the age border? I don't know. There is not a strict age border, but I say, let's say 65, 70. I don't put those patients anymore on the traction table. A patient with a real sciatica. Remember, lateral protrusion with pressure against nerve root. Yeah, but again, this is not so frequent. If this patient has motor deficit, the protrusion is too big. Don't put him on the traction table. If this patient has a big deviation, let's say a lateral deviation or a flexion deviation, I talk intensively about the importance and the interpretation of deviation in my previous webinar, which you can view on the online masterclass if you want. Yeah, super important. Big deviation. If the patient has a lateral, even if he doesn't have a sciatica, but just back pain, and he has a big deviation, a big lateral deviation, don't put him on the traction table. He's not going to like it, and certainly not afterwards. But I have some good news. When a patient has a sciatica, and this is something also discussed in other parts of the masterclass, a sciatica, lateral protrusion with pressure against nerve root, has a spontaneous evolution. That means when you don't do anything, automatically it goes okay. It comes okay. There is a spontaneous evolution. How that works, I explained that in other classes. Yeah. But there is something super important to know. If a patient has already more than 6 months of leg pain, we are over half of the spontaneous evolution. The spontaneous evolution is about 8 to 12 months. So when the patient has more than 6 months leg pain, no back pain, then don't put him on the traction table. It's useless. Yeah, keep that in mind. Not so frequent, but okay. In the meantime, I see in the chat, but not a public message, but a private message from Nina, that what about in patients with scoliosis that have a nuclear type disc protrusion? Well, no problem. I don't care about scoliosis. I'm not talking about a Formula 1 scoliosis. I mean a super scoliosis, which you sometimes see with children. I'm not talking about this. I'm talking about a minor scoliosis in just adult people. I don't care. This is irrelevant. If the patient has a symptomatic lumbar internal derangement and he has some minor scoliosis, traction table, no problem. Okay. And then another message came in, private message. Why does annular protrusion react better on manipulation than mechanical traction? Yeah. Well, I'm going to reverse the situation. Our main indication, remember, I go to the previous picture, our main indication is a nuclear protrusion. The nucleus is softer. If you do manipulation on, let's imagine a balloon with water, and you put your finger in the balloon with water, yeah, you're going to get a displacement of this water, but when you remove your finger, boop, everything comes back again. Well, manipulation doesn't, the high velocity, low amplitude thrust doesn't have so much influence on this soft nucleus. A continuous mechanical traction, you have a continuous suction force, has a better influence on the nucleus and not so much on the annulus. I don't say you have zero effect on the annulus. I don't say that. I just say it is less optimal. Okay, what else do we have in the contraindications? Remember the primary posterolateral protrusion I was talking about? If this is already there more than 3 months, forget it. Pregnant ladies, as from 4 or 5 months, that seems logical because you have to close the pelvic belt. But if the baby is over there, that's not going to be so nice for those ladies. Patients with cardiac problems, respiratory problems, or for instance, they just have a cold and they are sneezing all the time and they are coughing all the time. Sneezing and coughing while the patient is under traction is not a good idea. It could be painful. Yeah, keep that in mind. Even laughing under traction could be painful. So when you're talking with your patient while he's lying there, don't tell good jokes, yeah, because that could be annoying. And whenever the patient says, "Get me out of here," yeah, it happens. It doesn't happen a lot, but it happens. Yeah, you close the belts, you build in the traction, and 30 seconds later, the patient says, "How much more time?" And then I say, "What? Another 20 minutes." And then you immediately see the face of the patient changing. Oh, no. They have some kind of claustrophobia reaction on the traction table. The only thing you can do is stop. So that's why certainly the first 5 minutes you have to be in the neighborhood. If such a reaction comes, it always comes very soon at the beginning. Yeah? So inform about that. Make sure the patient is relatively comfortable. It may not be, remember the castle I showed you, it may not be a torture procedure. Yeah, okay. So it's obvious for everybody that it's all about patient selection. Yeah, to put the correct patient on the correct moment on the traction table. So how do you do it in a practical way? Well, in literature, you can find 5 or 6 different positions. To be honest, we don't need that. I think we don't need that. We just need 2 positions. On the left side with the flexion bench, this is an ideal position if his extension in standing in the examination is good. Yeah? He shows a good extension, but flexion is problem. Take that position. If extension is painful or limited, and I lost what I was going to say. I have a slight moment of Alzheimer light. Yeah. Let's rephrase that again because I want to make sure that you really can follow. I go back to the left side. The flexion bench. If extension is problematic, because I just see that I made a mistake here in my slide. That's why I was confused. Sorry about that. But on the left side, the flexion bench, you use that when extension is a problem. When extension is problematic, they're going to feel more comfortable in that position. When extension is good, then you use the position on the right side. So please switch it. Okay. Before I start with the traction, I always ask to the patient, are you comfortable in this position? Before I build in the traction, is it okay like this? Huh? And if it's not okay, change something. And then the magical mystery question, the question that always comes back: intermittent traction or constant traction? Well, those machines, those traction apparatus, they have pre-programmed settings, many of them, and with so many kilograms for so many seconds, and so many kilograms for so many seconds, and so on and so on. All of this is, forgive me the expression, is nonsense. It's just show. You don't need that. The only thing you need is continuous traction. And all references that examine that show that continuous traction is more efficient than intermittent traction. So all this blah, 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 all these pre-programmed settings, you don't need that. Yeah, and then they talk about indications for intermittent traction, mobilizing stiffness in the motion segments, and blah, 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 blah. Well, I can be very short about that. Irrelevant. So my advice is constant traction, okay? And forget intermittent traction. I don't say intermittent traction is not good. You could have results with intermittent traction, but I do say that constant traction is better than intermittent traction. So keep that in mind. Okay? Good. How many kilograms? That's another magical question. In literature, you find many different options, from 5 kilograms to 95 kilograms. Whoa. What you see over here, minimum 36 or minimum 25% of the body weight, well, that's a huge difference. Huh? Let's imagine the body weight of your patient is 60 kilograms. 25% of the body weight is 15 kilograms. My advice is try to start with minimum 36 kilograms and not with this 15 kilograms. What's the difference between the two? Well, if you use a traction force of 25% of the body weight, then you can get a vertebral separation. Yes, this is possible. Who cares? I need a vertebral separation which is big enough to reduce an internal derangement. And this is something else. And then, according to the other reference, you need at least 30-35 kilograms. And perhaps you might say, oh, a patient of 60 kilograms body weight, and you're going to give 30-35 kilograms traction force. Oh, help. This is comfortable. This is patient. Oh, there is a difference between the perception and what the patient actually feels. This is also one of the questions here. What is the patient feeling during this traction? Well, he's feeling some tension. That's it. Keep in mind one little detail. If during the traction the patient gets more leg pain or he produces leg pain, stop the traction. This is not interesting. Yeah, the information is interesting, but that's not good for the patient. Whatever you do when you get a peripheralization of symptoms, stop. But again, I can talk 2 days about lumbar spine, and I also do that in the online masterclass, but I have something very special to share with you a little bit later on, so don't run away. Some more references which you can read later on. And as you can see in this literature overview, well, traction force less than 25% of the body weight until 95 kilograms. Well, I can reassure you, 95 kilograms, I never did that, and probably I won't do that. The maximum is not so important. The minimum is more important. And to be honest, mostly I'm somewhere between 36 and 45 kilograms, depending a little bit on the morphology of the patient. But mostly I don't need more to have some good results. And yes, a general remark when we talk about scientific references, literature, at all times, use your own gray cells. You have a beautiful set of gray cells, use them. It's not because something is published that it also has some value. Keep that in mind. Yeah. in the British Medical Journal, they say that at least 50% of the studies which are published are rubbish because their methodology is not okay and some other reasons. So keep that in mind. So when you read some articles about certain topics, think, okay? Another reference that goes in the direction or that shows the effect of the negative pressure. This is here a very beautiful reference published in Spine, top journal. What do we see? Young patients, not elderly patients. Traction force of 45 kilograms. And what did they see in this group of patients? With the central protrusions, there was more success in reduction and less with the lateral ones. And this is logical. The more central an internal derangement, the more you also have the effect of the tension in the the posterior longitudinal ligament. Remember at the beginning of this session, I talked about that? Yeah. The more lateral a protrusion, so a real sciatica, this effect from this ligament, this extra effect doesn't play anymore. The more lateral an internal derangement, the more difficult to reduce it. And this is not only for traction, this is also for manipulation, this is the case. Yeah? So if I have a patient which falls in my indications, but he has a sciatica, I say in advance, we can try traction, but it's 50-50. When we're lucky, okay, well, here it's 57%, but let's say 50-50. We could be, we could have luck, we could have bad luck. We have to be honest with that. And this is just a biomechanical reason. Make sure you have good belts. And my advice is to put on the belts, certainly the pelvic belt, with the patient in standing position. Yeah? Make sure the hook between the legs of the patient is nicely in the middle. Otherwise, you're going to get some torsion in the traction, and this is more uncomfortable. Another little detail, those belts have the tendency to glide. That happens. And of course, for obvious reasons, the female body is more suitable for traction than the male body. Yeah, on the female body, the belts are a little bit more blocked on the pelvis and beneath the breast. The male body, which is just some kind of block, the towels are going to glide much more easily. So put a towel between the clothing of the patient and the belt, and then you're going to avoid too much gliding. Okay. And okay, how much time is the patient going to lie on the traction table? Well, the first session I start with about 20 minutes, but as from the next session, we don't need more than 30 minutes. You saw in the previous reference, there was about 40 minutes, but in another reference, we saw that the biggest physical change takes place in the first 20 minutes of traction. So I don't put my patient for 40 minutes on the traction table. 30 minutes is enough. Okay. But then a very important detail, when we release the traction on all those machines, you have a release speed button, which you can see there on the left side. Choose the slowest possible release speed. Let's imagine a patient got 40 kilograms of traction. Try to release that in about 1 or 1.5 minutes, slowly. This is much more comfortable for the patient. If you release that in just 20 seconds, because with some machines, the slowest release speed is 20 seconds, 15, 20 seconds, and that's it. This is not so comfortable. Could be problematic for the patient, could be painful. So choose a slow release speed. And then after the traction, you open the belts. You do that slowly. I suggest to start with the pelvic belt, with the breast belt. Then the patient finally can breathe a little bit more or more intensively. Do that slowly, because if you do that in a little bit too optimistic, the patient could get a twinge. And then the patient would like to step down from the table and say, no, wait. You remove the flexion bench or the cushion, and you ask the patient to do one hip flexion. Sometimes this first hip flexion is very painful. Then it's a good idea to do the hip flexion passively for the patient. But just the first movement was painful. And then do it a few times. Left, right, move a little bit. And then it's quite comfortable pretty fast. Then you ask the patient again to flex the hips and the knees, put the knees together, and then move a little bit from the left to the right. You do that also a minute or so. And then you ask the patient to push up the pelvis from this position and come back, and also do that for a minute or so. Actually, the transition from the negative pressure, minus 40 kilograms negative pressure, to standing up, body weight, gravity force, this transition we need to do in a slow way. This is super important for the comfort of the patient. If you don't respect that, then he's going to have more pain after the traction. Keep that in mind, okay? And then the patient can step off the couch in an ergonomic way. Yeah, she lies on her side and she rolls off the table, not from a supine lying position and coming up again. No, that's not the purpose. Yeah? And then, very important advice, the first 10 minutes after the traction, don't sit and don't do too much flexions. So mostly the patients come by car to the clinic. If you say, bye-bye, ciao, see you next time, and they immediately go to their car, they sit in the car and they drive away, this is not the best option. Let them walk around for 10 minutes. You know, my neighbors here in the neighborhood, they know if I have a traction patient, they know that. They see that the patient goes out of the clinic, yeah, and then disappears in the neighborhood for 10 minutes and then goes to his car and then disappears with his car. They know this is a traction patient because some of them also were on my traction table. Of course, as I mentioned before, there is no long-term efficiency. We have to respect self-treatment procedures. We have to give the patient prophylactic advice. How we do that, this is something I also extensively analyze and describe during the online masterclass and probably future webinars. And what is my specific strategy? What is my expectation pattern? Well, you do one traction treatment. What do you expect? Is it going to be better after one traction treatment? Nope. I don't expect that. I expect a change after 3-4 sessions. If you can do it every day. If it's possible for the patient, that's also an empirical element. If you do it on a daily basis, it goes faster, yeah, or the improvement goes faster. But give it 3 to 4 sessions. I expect first signs of improvement. If after 3-4 sessions nothing changes, zero change, stop. Then traction is not the ideal strategy for this patient at this moment. We have to find something else. Okay? Mostly we need about 10 sessions. Maximum 15. It doesn't make sense to give a patient 20 or 25 traction sessions. No. Mostly somewhere between 5 and 10. And as I told you, if possible, try to do it daily. I also have patients where it's not possible. I also see patients who have 3 times per week traction. Okay, so be it. No problem. Okay? And then, yeah, one of the questions I received here also in my paper is, I don't have a traction machine. Is there any alternative? Of course, yeah. What you see here are two examples of manipulative techniques in which we also have a traction component. Of course, this traction component is going to be less than the mechanical traction. That's logical. But we still have some kind of traction component. Well, you can adapt those techniques so it's not high velocity, low amplitude, but you can do those techniques in what we call in a nuclear version. Yeah, you stay in this position for about 20 seconds, which you incorporate your complete body weight, yeah, to get the traction component. Stay there for 20 seconds, release the tension, do it again, and you do that for several minutes. And it's quite possible. It's quite possible you're going to see a change. Yeah? More about manipulation, more about strategy of manipulation, which technique, when, how many times. Also, this is explained extensively on the online masterclass. Well, I still have a promise. Yeah? I told you that at the end of the story, you will get the slides and you will also get a handout on traction. But give me just a few more minutes, because perhaps now is the time to ask you if you have any other questions. If you have any other questions, just throw them in the chat, and I'm going to be happy to help you. Well, in the meantime, I'm going to have a look at some other questions here, and there's one particular question which I liked very much. Where is it? Can traction be used in patients with spondylolisthesis and disc herniation? I love that question. Why? The spondylolisthesis is something you can see on medical imaging. And then mostly the major mistake is happening. The patient has symptoms, and we see a spondylolisthesis, 1 + 1 is 2. No, in orthopedic medicine, 1 + 1 is always 3. You have to be sure that the spondylolisthesis is responsible for the symptoms of the patient. And how do you know that? This is the importance of the history of the patient. I have an extensive lecture on the history of lumbar patients, also on the online masterclass. Spondylolisthesis has a totally different history than an internal derangement patient. And what is that history? Those patients say, I have pain on walking and standing, which disappears within 1 minute on sitting and lying. This is different than derangement. The derangement says the reverse. He says, I prefer to be on the move. I don't like to sit too long. So if the patient, you see a spondylolisthesis, and he says, I have pain on walking and standing, which disappears on sitting and lying, and there are no dural symptoms and no dural signs, I refer to the previous webinar, then the spondylolisthesis is the problem, and then this is a problem because physiotherapy and spondylolisthesis is an illusion. This patient needs surgery. So you're not going to put him on a traction table. If a patient has a spondylolisthesis which you see, but you don't hear it, the spondylolisthesis is asymptomatic, because most of them are asymptomatic. But you hear the story of an internal derangement, the things we just discussed in this webinar. Oh yeah, you can put him on a traction table. No problem, because the internal derangement is his problem. Yeah? And not the spondylolisthesis. It's all about diagnosis, and then you set your treatment plan. I never said orthopedic medicine was easy, but it's so inspiring once you manage all the little details. Yeah, keep that in mind. There's another question I would like to refer to, but perhaps first I'm going to look in this chat. Oh, Luna is also a private message about the joke with Alfredo and the 5 fingers. Well, most likely you're not going to know what this is about, but this is something I tell during live courses, specifically when we talk about the strategy of friction massage. So be my guest on one of my live courses, and then you're going to hear this joke. But another question here. Lumbar traction for radiculopathy due to disc generation. Is that useful? In other words, radiculopathy, sciatica. But due to disc degeneration, is that useful? But we talked about in the indications and the contraindications, we talked about sciatica. But let's imagine here the question, disc degeneration. Yeah, we're not talking about a disc protrusion against the nerve root. We're talking about not enough space in the foramen intervertebrale. The nerve root is squeezed in. You have some kind of stenosis. Stenosis also has its typical story. And stenosis is not an indication for traction. You're not going to put him on a traction table. Perhaps during the traction he's going to feel a little bit better, but nothing is going to change because it's a structural problem. You can't influence the stenosis. Yeah? Okay? So keep that in mind. So, what's next? Well, the mission of myself and my team is we give courses worldwide, and our mission is not only to give high quality courses, but to also give those courses to make it affordable for most of the therapists. Yeah. Actually, it should be a super investment for you, but you don't need to pay too much. And you know what is the most frequent question I get when I talk about our courses worldwide? You see the website address cyriax.eu/worldwide. There you find what we are doing all over the world. You know what is the most frequent question I get? Do I receive a certificate? This is the major question, the number one question. Yes, you receive a certificate. But what is more important? Many people, they follow live courses, fortunately. But let's be honest with each other. 4 weeks later, 2 months later, you forgot 70% of what you have seen during the course. And perhaps you apply in your clinical practice 10%. So what was the purpose? What was the value? Yeah, you did a course and you have a nice certificate at the wall. But did you improve? Did you improve as a therapist? Did you discover new things? Did you grow? And that's a little bit, everybody has to ask this question for himself. Yeah? Actually, repetition is the key of successful learning. And I see also in the chat, Dr. Sunil, thank you very much for your kind feedback. Well, you don't know that, but I know Dr. Sunil was one of my guests in the Mastermind private training program, and he certainly can confirm that repetition is the key of efficient learning. You're not going to get it just by hearing something once and by doing something once. Repetition is the key of successful learning. And for this purpose, I created a new online learning platform. And today today I'm going to do a special offer. It's the first time I do this offer, honestly, only for you, only for the people who are attending this webinar, only for you. Yeah, we have the online edition of 15 live courses, 15 days live courses, the complete course in orthopedic medicine, everything. We have it online. And you can watch it whenever you want, on your tablet, on your smartphone, on your computer, whenever you want, how many times you want, whatever. And actually, we have two levels. We have a silver level and we have a gold level. But you see the prices over there. But you can already forget that, because today and only today, I have something special for you. You not only have the complete course in orthopedic medicine, including the clinical reasoning exercises, the true-false questions, some certification tests, and so on and so on. You can discover everything on this website, orthopaedicmedicine.eu. But you not only have the films, but you also have a lot of downloadable material. And let me show you. Let me show you this package. Voila, it's quite a lot. You have one handout, well-illustrated handouts with all the information you need about clinical reasoning and treatment strategy of, where am I now? I have to go back. Treatment strategy of the most common lesions in the upper and lower extremity. We have a second book, Everything You Need to Know About the Lumbar Spine. We have a third one, Everything About Cervical Spine and Thoracic Spine. We have number 4, the advanced material on upper extremity. And we have number 5, the advanced material on lower extremity. There are no scientific references in these books. Those are practical handouts, things you can use in your clinical practice. On the platform, just PDF, download, it's on your computer, and they are yours forever. As easy as that. And if you look on the right side of your screen, then you're going to see now that a link is appearing. Use your discount code webinar55. Well, if you click on this link, you're going to see the registration page. And for just €149, you get access until 1 April 2022. Yeah, more than 1 year. Everything you need. You also have the recordings of the previous webinars, some other lectures, the next webinars. Everything is on this platform. And just let me show you. If you click on the link, you're going to see this page. It's very easy to register. You just scroll down and you click the gold upgrade, and then you're going to see that the price is changing, that this is €198. But then you're going to use your webinar 55 code, and you click on the arrow to activate your code, and then you see the price automatically changes in 149. The only thing you have to do is just choose your payment methods. You can pay with credit card, PayPal, everything you like. So it's very easy. So when you do that, immediately you're going to get an email with your login data, where you can find the course and how you can enter all those material. You just pay once and you have access until 1 April 2022. On the website, you see also some references from people who already signed in and already joined the online masterclass. But there's another surprise for you, a new surprise today. When you sign in for the online masterclass, and when you say, I have some colleagues who might be interested also to join, can they also have the same promotion, the same benefit as what I proposed to you today? then the answer is yes, and even better. You just go to the website /affiliate, and then you're going to see how you can earn money yourself with your masterclass. Have a look. But it's beneficial for you and for the colleagues. Only one little detail. This is a super offer. How much do you pay for 1 day live course? Central Europe, you pay even more than this amount per day. So how much do you get for this amount? Well, this is our definition of making efficient online learning available for everybody. So you have 2 hours time, 2 hours from now. Yeah. After 2 hours, it's not going to be possible anymore. I would say join the club. Okay. So, as promised, some extra downloads. Let me look here for the downloads. I'm going to remove the offer, and then we go over there. Voila. Then on the right side, you're going to see the handout, and you're going to see the slides. Voila. As from now, you just click on the links and you have this material in PDF. So we are at the end of today's story. So do you have any more questions at this moment? Because now is the time. So if you have any more questions, feel free to put them in the chat. If the questions are coming later, don't worry. You can send me an email, or you can go to the website /support and you can put your question over there. You're going to receive shortly an email with the replay link of the webinar, so you can watch it again whenever you want. And if you have any further questions, you know where I live. So I see that there are no more extra questions. So thank you very much for joining this live event today. I hope you enjoyed it very much. Thank you for the kind feedback. And take your agenda, 27 March, Saturday, 27 March, the next webinar is coming. What is going to be the topic? It's a surprise for you, a surprise for me. But 27 March, I'm back live. Okay? So enjoy your beautiful day. And as usual, I have to say goodbye with a view on the beach. And the weather over here is fantastic today. So most likely I'm going to be over there this afternoon. So thank you and all the best, and see you on the next occasion. Ciao, ciao.